I'll just share my slide. Is the slides visible?
Yeah, yeah.
So I would like to thank Santan for giving me the opportunity, and I would also like to thank Santan and Bhushan specifically for giving me the slides for this presentation. So we are going to be basically discussing on efforts to look beyond just symptomatic relief in dry eye and what do some of the clinical and preclinical studies tell us. So when you look at dry eye, according to the latest DUSE-2 guidelines in terms of definition, the most important words are that there is a loss of homeostasis of tear film, there is tear film instability, there is hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities are there. So all these together play a role in making the patient symptomatic and causing changes on the ocular surface. And when you look at classifying dry eye, you would basically broadly categorize them into an aqueous deficient dry eye or an evaporative dry eye. And the aqueous deficiency is further subcategorized as either being a Sjogren's or a non-Sjogren's dry eye, and the MGD is categorized as being caused either because of an intrinsic pathology or an extrinsic cause. There's also another way of classifying dry eye apart from the DUSE-2, and this was actually given by the Asia Dry Eye Society, and there they came up with the concept of tear film oriented diagnosis and tear film oriented therapy, where they primarily looked at the stability of the tear film with respect to the tear film breakup and the pattern of breakup. And based on the pattern of tear film breakup and the timing of tear film breakup and the movement of the tear film on the ocular surface, we would be able to categorize what is the component of the tears that is affected, whether it's the mucin which is affected, whether it's the aqueous which is affected, or whether it is the lipid layer which is affected. And based on the primary component which is affected, they came out with an algorithm as to what would be the lubricating drops or what would be the medications that would be given. So when you look at the in general algorithm, when we look at a dry eye treatment pattern and when we start treating patients, you have environmental strategies which you might need to address. Most of us primarily look at tear film supplementation with artificial tears, and that forms one of the most important arm of our treatment. But as the disease severity increases, you would have to consider tear retention strategies, stimulation strategies, and biological substitutes, along with the role of anti-inflammatory therapy. The DUSE-1 guideline initially came up with a very good algorithm in terms of the grading of the dry eye and the medications that you would use in each grade. And the DUSE-2 continues with the same, there's with a few additions. So when somebody is graded with a step 1 dry eye or a level 1 dry eye, you're basically looking at just environmental or dietary modifications or removing or eliminating the offending agents. You're looking at eyelid therapies if there is a little bit of MGD. Step 2 is actually important because this is the time that we would be shifting from probably a preservative lubricating drop to a preservative free lubricating drop. And here is the role for an anti-inflammatory molecule such as cyclosporine. And in fact, if we delay the use of cyclosporine beyond this and it goes to step 3 or step 4, then maybe even cyclosporine would not work. The newer additions today with the advances would be in terms of probably using lipitigrast, even though it's not available as yet in India. Topical chloroquine we do have available in India, and some of us do use it, but again there's not much of literature based on its use. Again in step 2, especially with the advances in meibomian gland treatment technology, you could probably put in the LipiFlow or the IPL if the MGD is severe. You could look at punctal plugs as temporary measures in step 2, and if it progresses to step 3, you're looking at a permanent occlusion with either a cautery or a permanent plug, or you're looking at therapeutic contact lenses such as the PROS lenses or biological substitutes. And surgical options would be for a step 4 where there's already ocular surface significant damage. So when you come to sodium hyaluronate, a 0.1%, and when you look at the mechanism of action versus some of the other lubricating drops in the market, an artificial tear supplement basically just replaces the water and it washes off whatever debris is there on the ocular surface. Whereas sodium hyaluronate, in addition to replacing the tears, also increases the stability of the tears on the ocular surface, and it has a beneficial effect on the corneal epithelium, and it accelerates epithelial healing. So when you look at what are the evidence, you have either in terms of preclinical evidence and clinical evidence. So when you look at preclinical evidence and you look at cultured rabbit epithelial cells, In cultured isolated rabbit corneas, sodium hyaluronate was shown to facilitate the adhesion and the expansion of the epithelium over a period of time. And when you extrapolate it to rabbit corneas, where you experimentally induce an injury, either with the use of N-heptanol, which preserves the basement membrane, or with the surgical removal of the epithelium where the basement membrane is already damaged. And if you look at a vehicle versus a 0.1% hyaluronate versus a 0.5 or a 0.3% hyaluronate, and look at how the healing happens. And this was basically the study design, where they put the medication immediately and then at 2-hourly interval for 4 times, and then the experiment 2, where they started the drops immediately at 2-hour intervals for 4 times, and then 2-hourly in the next day. So when we looked at the wound healing response in these rabbit corneas compared to vehicle, the 0.1% sodium hyaluronate stimulated wound healing regardless of the presence or absence of the epithelial basement membrane. But between a 0.1 and a 0.3, the 0.3 facilitated a faster epithelialization if the basement membrane was also damaged. It decreased, so to conclude, sodium hyaluronate decreased the time required for wound closure, and almost within 48 hours, the surface was epithelialized. And this was independent of the molecular weight, but it did depend, like I said, on the concentration of the sodium hyaluronate. So to conclude, when you're looking at an epithelial healing, you're basically looking at 3 steps: a migration of the epithelium, a cell division, proliferation, and a cell differentiation. So very early in the injury phase, sodium hyaluronate does promote healing by facilitating a movement of the epithelium on the surface, and it very quickly reestablishes the epithelial barrier on the bed. And a 0.1 was effective for mild damage with a relatively intact basement membrane. So when you look at sodium hyaluronate concentration and molecular effect versus the other molecules in terms of chondroitin sulfate, chondroitin, keratin sulfate, the sodium hyaluronate significantly affected the epithelial wound healings as compared to the other molecules. So just to conclude it again, it basically sodium hyaluronate facilitated adhesion and expansion of the epithelium, significantly promoted extension of the epithelial layer as compared to a control group, and helped stimulate wound closure in a dose-dependent manner. So when you look at clinical studies of sodium hyaluronate, so if you look at what is called as the breakup index, which is basically a ratio of the breakup time after installation of the drop versus the breakup time before installation of the drop. The artificial tears as well as sodium hyaluronate initially increased the breakup time significantly, but this effect was more sustained or more long lasting with sodium hyaluronate as compared to a CMC based vehicle. This is a phase 3 study where sodium hyaluronate was compared with a control vehicle, and one eye of the patient was given sodium hyaluronate and the other eye was given the control vehicle. And the evaluations are basically in terms of the subjective symptoms, which were either improved, markedly improved, slightly improved, unchanged, or worsened. The objective findings, which were based on the fluorescein staining at 2 weeks and 4 weeks as compared to the baseline. There was also a questionnaire on the global improvement between both the eyes, which was independently rated, and the overall safety or adverse effects were also noted. So when you look at sodium hyaluronate versus the vehicle group, almost about 50% of the eyes which received sodium hyaluronate showed that the patient said that they felt it was useful or very useful as compared to their pre-drop phase. When you look, and this is just another graphical representation of the same data. When you look at their objective and subjective rates of improvement, also sodium hyaluronate scored much better than the placebo, and this difference was statistically significant. And when you look at objective improvements alone, disregarding the subjective improvements, the difference was also statistically significant. And in fact, the objective parameters were much better as compared to the overall global or when you add the subjective parameters as such, indicating the beneficial effect of the molecule on epithelial healing or epithelial regeneration. As far as safety profiles are concerned, there were a couple of patients who had conjunctival edema or allergic conjunctivitis, but that was not something which was seen very commonly. It was as for any lubricating drop available in the market. So to conclude, based on the combined subjective and objective findings, there was significantly better overall improvement in eyes assigned to the sodium hyaluronate as compared to those treated with the vehicle. The objective improvements were slightly better as compared to just the subjective improvement. This was again with hair dry, we are basically worried about the use of a preservative, because we always look at avoiding preservatives, especially when we have to use lubricating drops for a prolonged period of time. And even if you look at the DUCE 2 guideline from level 2, we say you have to use a preservative free molecule. So when you're looking at hair dry as an option and the presence of BAC is there, so obviously there would be a little bit of concern. So this study looked at the use of preservative-free sodium hyaluronate versus the BAC, which basically has a preservative versus sodium hyaluronate with BAC of about 0.003%, and the dosage was more than 6 times in a day. Again, basically the objects were objective improvement, subjective improvement, and the patient impression along with the side effects. And the side effects in eyes with preservative and without preservative at a concentration of 0.003 was almost similar. So at such a low concentration of BAC in these eyes, it was not making a significant difference to the ocular surface. Again, why is this? It is probably related to the version of BAC. So if you have a BAC C12, the damage to the ocular surface by a BAC C12 is much lesser as compared to a common BAC mix, which causes significant more ocular surface damage, as seen by this scanning electron microscopic images 10 minutes after application of both the drops on a stem cell growth. So if you are looking at a long-term administration and whether this long-term administration of drops with a lower concentration of BAC causes a problem. So we looked at this study, which shows up, this is an in-house data from Santen, which looked at sodium hyaluronate 0.05%, 0.1%, and 0.3%. And for the long-term 1-year data, they looked at sodium hyaluronate 0.1% and 0.3%. And again, graded it based on subjective and objective findings. And the overall improvement was seen in almost 53% patients. And most of them had moderate or more improvement. So unlike a standard BAC, the C12 BAC in sodium hyaluronate has less toxic effects. And even after almost about a year, the patients do have an improvement in their symptoms and in the ocular surface status. So compared to conventional BAC, the toxicity of the C12 BAC seems to be much lesser. So in summary, basically sodium hyaluronate addresses both the aqueous phase of the tears because it acts as a lubricant. It holds on the lubricant on it, the tears on it, almost 6,000 times its molecular weight. And it also attaches to the mucin, stabilizing the tear film on the ocular surface. It helps faster epithelialization of the ocular surface, and it stabilizes the epithelial alterations in patients with dry eye, and thus it improves the epithelial damage, and it improves both the subjective and objective signs of patients who have dry eye disease. In addition, with respect to specific corneal wound healing and corneal epithelial regeneration, it seems to be playing an important role. So to a certain extent, post-surgery patients, like what the previous speaker said in terms of post-LASIK or post-cataract surgery, this might be a useful lubricant to use. Thank you.
Thank you so